Okay, we're going to begin this video talking about ventilation alarms. First thing is that you never ignore an alarm, and nurses oftentimes experience what they call alarm fatigue, where it becomes like white noise, all of the alarms that they hear, and so you tend to ignore it. So it's just like the way you would ignore perhaps a radio in the background while you're studying. People begin to ignore alarms, but there's been lawsuits where the patient's family have won considerable amounts of money because of the alarm fatigue that was experienced. So the first thing is never ignore the alarm. This also means that if you have a patient with a ventilator, you need to be within earshot of that patient so that you will be able to hear the alarm when it goes off. The vent has three types of alarm. One is high pressure, one is low pressure, and the other one is when there's something wrong with the machine. The one when there's something wrong with the machine, you're going to call a respiratory therapist because they sort of take care of that machine. But you can troubleshoot the high pressure and the low pressure alarms. Because even if you have respiratory therapy as a backup, every time an alarm goes off, you can't pick up and call them. Okay, or they're going to just, get call fatigue from you. So you need to be able to troubleshoot a certain amount of these, and a lot of them go off, and they're very simple fixes. So high pressure alarms are anything that prevent air from moving in or out. So anytime there's a blockage or something that's preventing the flow of the air to move easily, you're going to have a high pressure alarm. So frequently, high pressure alarms go off because there's secretions in the airway, okay? Which means you need to suction the patient. Sometimes there's what we call overcondensation in the tube. So remember that the air is humidified. Sometimes that mist gets, comes together and pools in some of the tubing, and it makes like a little puddle in the tubing, for lack of a better word, and it will impair the ability of the air to move smoothly, and you'll have a high pressure alarm go off, okay? All that needs to be done is that condensation, gets rid of that condensation, and you'll be fine. There could be a kink in the vent tubing, okay? The patient biting on the ET tube, the patient coughing, gagging, or trying to talk, okay? Or the patient's experiencing increased airway pressure because of a physiological problem, like a bronchospasm, where the bronchus becomes tighter, or a pneumothorax, where there's a pushing on that airway. So those are high pressure alarms. So clearly, if you're going to hear a high pressure alarm and then call the respiratory therapist, and all that needs to be done is your patient needs to be suctioned, then they're not going to come running too much when you call, all right? So the first thing you're going to do is look at it, see if you can troubleshoot it. You go through these things and say, okay, is there a kink in the tubing? Is the patient trying to talk to me or coughing or biting on the tube? Maybe they need to be suctioned, okay? And then you kind of investigate whether or not there's a more complicated thing like the airway pressure from a bronchospasm or pneumothorax. Low pressure alarms mean that something's not connected. So either the tubing has become disconnected from the ventilator, or the endotracheal tube or the trach tube has been displaced. Sometimes you'll walk in the room and you'll see a low pressure alarm, and there is the ET tube sitting on the patient's chest because they've either pulled it out or they've coughed it out. So that's an example of a low pressure alarm. Now, clearly, you don't intubate. We only have physicians intubate. And you're going to need to call for help if that's the case. But a lot of times things just sort of pop off, maybe after the patient's been repositioned. So that's an example of a low pressure alarm problem that you could troubleshoot. Now, sometimes the patient has other alarms that go off, and one of them is a high respiratory rate alarm. And what happens then is the patient sort of overbreathes on the ventilator. So you set the ventilator so that the patient has some control over their respiratory rate. But if they go too high, you want the machine to tell them. So let's say you let the patient breathe as much as 28, let's say, breaths per minute. But the minute it goes over 28, you want to know about it. So you would walk in the room and assess the patient because the high respiratory rate alarm is going off. So a lot of times this means that the patient has anxiety or is in pain, okay? Other times it means that there's secretions in the airway and the patient needs to be suctioned. The patient could be hypoxic or they could have rising CO2 levels. So you really need to assess the patient. So assess the patient for anxiety or pain. Consider, suctioning the patient if it hasn't been done. Look at the patient's O2 sat and see what their O2 sat is running, and then you can kind of troubleshoot that high respiratory rate alarm. Low exhaled volume usually means that the tube isn't connected. So there's some piece of it that's not attached. It can also mean that there's a leak in the cuff of the endotracheal tube or the trach, or that there isn't enough of a seal. So remember back in another video I talked about how sometimes the balloon has a slow leak in it. So this would be the alarm that would go off if the balloon became deflated. Sometimes the low exhaled volume alarm is triggered because there's another alarm that is causing full delivery of a breath. So a lot of times it can get kind of noisy and you'll have a few alarms going off at the same time. But again, we should never ignore the alarm. So the effects of, okay, let's try that again. So the effects of positive pressure ventilation, we already talked about cardiovascular complications, and that's really in the form of decreased cardiac output. So whenever a patient's placed on a ventilator, their blood pressure will drop. Now, most patients can compensate for this, and what you'll see is that the blood pressure will go back to normal. However, oftentimes they still have a heart rate that's a bit increased, and they also will have an increased systemic vascular resistance. Now, a lot of these patients that we see aren't too stable to begin with, so a lot of times they're hypovolemic or they have other things going on that affect the cardiac output as well. So it's something to consider when you put a patient on a ventilator, how much other support with blood pressure are you going to need to put the patient on. This doesn't mean too much to you right now, but it will later on in the course when we talk about hemodynamics. Okay. The other thing to consider is if you have a patient who's on a ventilator and they add PEEP, PEEP really can drop the blood pressure considerably. And while it does a good job at improving the patient's oxygenation because it gives that alveoli more time to remain open and receive oxygen, it is troublesome when the blood pressure goes really low and the patient gets particularly shocky because of it. So there's other complications. We talked about pulmonary ones, one of them being ventilator-acquired pneumonia, and we'll get into that a little bit later. But another problem with this is if you consider what's happening to the patient, we're basically blowing air into their lungs. And so patients can develop what's called barotrauma or volutrauma. And what you'll see is increased agitation and coughing. You'll see the high-pressure alarm go off frequently. You'll see that the breath sounds are very much diminished, and the patient sometimes will develop subcutaneous emphysema. And it doesn't really do much to improve their ABGs. Other things that can happen is that the patient is at risk for oxygen toxicity. Oxygen toxicity is something that can happen, but unless we're talking about a pediatric population, it's not something that we see too terribly much because it's pretty easy to control the oxygenation on the patient. And usually these people, the problem is they haven't got a great oxygenation, so giving them too much oxygen is usually not too much of an issue. Neurovascular-wise, there's decreased venous return from the head, and so sometimes the blood flow to the head is decreased, and it's particularly decreased if the cardiac output is low. So what you might see is symptoms of increased intracranial pressure and altered levels of consciousness. Now, a lot of times this gets masked because we are placing the patient on paralytics and medications to sedate them. But that's something that needs to be checked. Commonly, we'll see patients have problems in the renal area because the patient has developed a low cardiac output and there's less blood flow to the kidneys. So usually if there's renal complications, it's a direct result of the low cardiac output. You can also see water retention in these patients, so they'll become edematous. That happens quite frequently. Again, there's decreased blood flow to the intestines, and so patients on ventilators are really at an increased risk to form gastric stress ulcers. As a matter of fact, protocol for patients on ventilator usually include that they receive like IV protonics or some sort of proton pump inhibitor to prevent the formation of ulcers. Patients might complain of epigastric pain or burning, but you as the nurse should be checking for occult stool, blood in the stool, and looking at the hemoglobin and hematocrit to see if it's decreasing. So what are some of the things that we can do to prevent ventilator-associated pneumonia? Well, one of the first things we can do is to keep the head of the bed raised, and that's usually ideally between 30 and 45 degrees, unless there's another problem with the patient, and that usually is because the patient has a blood pressure that's too low. So the higher you can raise the bed to this ideal of 45 degrees, the better. But you can't do that and then risk the patient, going into shock or having the blood pressure decrease, because that's just going to cause a whole bunch of other problems. Another thing that they'll do is they'll give the patient frequent trials to see if they can get them off the ventilator. So at least daily, they will decrease the amount of sedation that a patient is receiving and see if they're able to breathe on their own and begin the weaning process, because the sooner we can get them off the ventilator, the less likely they are to develop ventilator acquired pneumonia. Hand hygiene is another thing. I know it seems very basic, but it's something that needs to be done. Cleaning inside the patient's mouth. So meticulous mouth care, which a lot of times gets ignored because the patient has an endotracheal tube in their mouth, right? It's a bit of a nuisance to get in there with a toothbrush, but they have found that patients who have mouth care regularly, and that means like at least every shift, have a decreased rate of ventilator-associated pneumonia. And then the other thing is replacing equipment on or use on different patients. You wouldn't believe how many times things get moved from one patient to another. I'm not talking about endotracheal tubes or anything gross like that, but sometimes the small pieces of tubing that gets overlooked and it doesn't get changed. But these are some of the things that you can do to prevent ventilator-associated pneumonia. All right, this slide has quite a bit on it, but I want you to pay attention to what we have down here where it says interventions to prevent common complications. So most patients on ventilators have what they call bundle orders, where they order a whole bunch of stuff automatically whenever a patient's on a ventilator. And that includes head of the bed elevated 30 degrees or higher, using an ET tube with continuous suction, oral hygiene at least 2 or more times a day. I'm going to go on a limb and say every 8 hours is probably better. And that includes brushing the teeth and the tongue, as well as moisturizing the mucosa. In addition, patients during cardiac surgery will also receive chlorhexidine rinse. Patients should be on deep vein thrombosis prophylaxis because these patients are more apt to develop that. So that includes things like TEDs, as well as compression stockings and pneumatic compression devices. Over here, we have drug therapy that patients are going to routinely be on when they have a ventilator. So that includes either histamine 2 receptor agonists, proton pump inhibitors, or mucosal protection therapy, and that's like a Carafate. And what that drug does is it sort of coats the inside of the stomach. They'll also be on anticoagulant therapy, either heparin or Lovenox. If they have any kind of predisposition to clotting, then they might be on IV heparin depending on the patient's condition. And what you need to realize, these interventions that we're doing for this patient are good in other conditions. However, in this case, we're using them because the patient is on a ventilator. There's other nursing diagnoses, as you can see down here, you can read those. And then these would be the outcomes. We want the patient to experience no complications from mechanical ventilation.